So welcome back, everybody, then, for session two, titled Using a Holistic Lens to Enhance Balance and Well-Being. This session is going to be presented by Dr. Siobhan Bell. Dr. Siobhan Bell has been practicing registered nurse since 2006 with the College of Nurses of Ontario. Her practice experience from 2006 until today covers a variety of practice environments, including long-term care, retirement, community, home care, acute care, medical surgical, intensive care, critical care, and the emergency room. And currently actively practicing as a sexual assault and intimate partner violence forensic nurse examiner, a nurse psychotherapist, and a professor of nursing for Seneca Polytechnic's RPN to Honors BScN program. Dr. Bell is also the current president of the Nurse Psychotherapy Association of Ontario and the education coordinator for the Canadian Forensic Nurse Association. Along with her busy nursing career, Siobhan is a partner to her husband of 22 years and mother to two boys, and lives with her family in rural Ontario with a collection of pets. It looks like a dog and a bird, as well as some chickens. Welcome, Siobhan, to the Education Day, and I'll turn it over to you.
Thank you. Thanks so much, Don. Um, I always hate listening to my bio. Talk about holistic lens and balance. I can definitely say that my whole career has been unknowingly about trying to create balance and trying to find the holisticness within my nursing career. So when they asked me to talk about a holistic lens and what that means for the nurse, I did immediately actually start with myself because I thought, well, how do you tell somebody else who's a nurse what that's like without really evaluating what it is for yourself? And I think for me, that's been a lifelong and will continue to be a lifelong journey that I have thankfully been taught by all of those wonderful nurses that have come before me and who continue to be mentors for me. Being the daughter of a nurse, being the wife to a frontline person, being the mother to children, being a friend, being a colleague. All of these things have shown me and taught me that nothing in our life, nothing that we do, whether it's in our personal life or in our professional life, is not needing a holistic lens. Everything needs to have a holistic lens. And that has never been more sort of prevalent in the front of my mind than it is now. So this is my two sons, the oldest who's 15 turning 16 and the little one who is 8. He'll be turning 9 in June. And my husband of 22 years who puts up with the fact that I've had a bazillion jobs in a bazillion different areas and am constantly going back to school. So I could not do the things I do without them. So when I was thinking about like what this could mean for us as mental health nurses today on Mental Health Day, I really went back to two things. One is the Nurse Psychotherapy Association of Ontario. When we were developing our foundation, we wanted to have a holistic lens on mental health nursing. And so we have defined holistic health for us and holistic nursing as that interconnectedness of biophysical, emotional, and environment. But the other nursing group that has done a great job of proactively approaching holistic health is the Canadian Holistic Nurses Association. And they define holistic health as the interconnectedness of body, mind, emotion, spirit, and environment. Ultimately, all of these things just talk about our ability to be and feel our best, right? That is ultimately the goal of being human, right? So what would happen if we paused and we thought about if we were our own best friend, what would a holistic lens on our life look like? Well, it would likely look like this: balance, compassion, and empathy. Because when we're talking to our best friend, we are thinking holistically about them. We think about the things that are important to them, the things that they've defined as being essential to their life. We're always compassionate to them when life is hard and things are really difficult for them. And we have empathy when they're not their best self. But often we don't do that same thing for ourselves. We can't really have balance in our life if we are not doing this. One of the reasons I put this in here is because I am the worst at this. It is absolutely one of the things that I have never been good at. I've always been someone who is a great friend, but not as good at balancing for myself that same quality that I would give to a friend. And so over the last 10 years, especially through the pandemic and through some personal challenges that I've had, which included having to rediscover nursing, I've learned that I have to learn to be my best friend in order to have a holistic view of my own life, in order to give my family and my loved ones my best self. I can't be my best self if I don't have balance in my life. And for me, that's about being realistic about my commitments. It's very easy for me to be too busy to do anything. It's very easy when you're balancing, you know, again, listening to my bio, right? I sit on 2 executive boards for associations. I have a private practice. I work as a forensic nurse. I teach. When you think about those 5 things, and then you add to that children, fur children, a husband, being realistic about commitment is really what balance for me is about. That might look different for other people, but ultimately what you're looking for is, do you have enough of those things in your life that realistically bring you joy? And as our keynote speaker said, bring you the financial balance also that you need, right? So it's about combining all of those things and being realistic about what we're committing ourselves to. I am at what I would call my peak commitment. I am about as maxed as I can get, and have been strategically, with support from colleagues, reevaluating some of my commitments, and will start to change as the spring and summer comes, because now it's my season of rebalance. So as if I was talking to my best friend, I would say, well, are you being realistic about your commitments? And I'm saying that same thing to myself now. Am I being realistic about my commitments? Compassion is hard. Being compassionate for yourself. I always thought that this was a no-brainer, right? Of course you're compassionate to yourself. You live in your own brain. How can you not be? It's actually a lot harder than it sounds. When we see hard things that are impacting our life, like if we think about the environments that we work in right now, there are not very many people who can say that they work in an environment that is not suffering the consequence of either fiscal challenges or staffing challenges or all of these things. Those hit our professional lives pretty hard. Then there's all of those things that are challenging to your personal life, like finances, right? Like our soaring grocery bills and rent or mortgages. The interest rates alone on mortgages has been such a huge hit for a lot of people. But are we actually being compassionate to ourselves about how these hard things are impacting our life? Most of us, if we were being honest, would probably think, no, what we're doing is toughing it out, because in a lot of ways, that's what nurses do, right? We pull up our socks and we get to work. You're going to get through it. We can see that the light is at the other end of the tunnel, but are we being compassionate to ourselves as we walk through that tunnel? So what does that look like? Well, for all of us, that might look different. For me, being compassionate is taking a break. If I was talking to my best friend, I'd say, well, when was the last time we had coffee? Or when was the last time we went for dinner? When was the last time we sat outside and just listened to the birds? Because I live in a beautiful part of rural Ontario. all of those things are being compassionate to myself, that pulling up my socks and working till I'm, blue in the face is not actually going to help me. But taking a break and taking a breather might be the most compassionate thing I can do, and is also going to create more resiliency. And that's a big thing that we want to look at when we're talking about our holistic self is, are we building our resiliency? And then empathy. I think in general, nurses are empathetic. We are a group of people who sees the worst things in life and finds a way to connect to the humanness of the person on the other side of it. We don't necessarily always give ourselves that same grace when we're struggling. I've seen colleagues who have struggled with substance abuse, and they are so the opposite of how they would be should they be dealing with a patient who has substance abuse issues. But they can't have that same empathy for themselves and understand that they're doing the best they can with what they knew. And now we're going to try to help them do better. We don't give ourselves grace when, we come home and we haven't eaten after a 12-hour shift, and then we scarf down an entire lunch, dinner, and dessert, and maybe tomorrow's breakfast all at the same time. And they were like, oh my goodness, that was such gluttony. Okay, yes, but would we say that to our best friend if they hadn't eaten for 12 hours and all of a sudden all of their favorite food is in front of them? So having empathy for how people process the tough things in life is also a really important piece of being kind to ourselves. When we have a holistic view of our world, we are creating balance and well-being. I often will tell my patients in my psychotherapy practice that for me, I always picture sort of those scales of justice in my head when I'm thinking about being pre-wired into that negative space, and how I need to feed the positive side of that scale in order to balance things out. When we look at our life through that holistic view, and this includes our work life, that worldview, that paradigm is balance. When we have a good view with balance, we create well-being, which is exceptionally important, I think. So if we take it to that macro lens and look at the paradigm of what a holistic view would look of our world, and we think of the body, mind, emotion, and spirit, and of course our environment, there's a few things that we can think of. For body, as much as this sounds simple, eat, sleep, love, and laugh. All of these things physically are essential to our body's ability to be connected and feel well. Mind, our mind needs to do things like reading and reflecting and challenging it and resting it. I can't stress the rest part enough, at least for me. Emotion, feel it. One of the things that nurses are really good at is not feeling, right? We get so used to and good at holding our feelings in because we are having to be present for other people that sometimes we forget to actually feel. Processing our feelings is important. Seeking out feeling is important, right? When we are in a place of sadness or we're in a place of burnout, we need to seek feeling that is positive and share feelings. We need to share our feelings. As humans, it's important to connect and share how we're feeling. Spirit, seek purpose, seek connection, feel your purpose. For everybody, this looks differently. For some of my colleagues and some of my patients, this is going to church. For some of my colleagues and patients, this is standing outside and listening to the wind and remembering why it was good to be alive, feeling why it is that we do what we do, seeking that connection to ourselves and to our world, and to, if this is part of your belief system, to a higher power. And then environment. This one you'll notice is bigger than all the other ones, and that's because it encompasses or encapsulates all of them. How we interact with our physical environment, how we take care of our physical environment, access to a physical environment that is safe and has connection for you. So for example, just walking along a concrete jungle is not necessarily going to do the same for you as finding a tree on the side of the concrete jungle to stand and look at. Advocating for our environments. Nurses are great advocates. We will go out of our way to make sure that the patient down the hall who wanted green jello instead of red jello gets the green jello. We can use those same tools to reach out and be better and louder advocates for better health environments that put patients and nurses and other healthcare practitioners at the center of decision making. We can advocate for environments that educate us in the ways that we need for the healthcare system of today. I know as a faculty member, I do that all the time. I maybe do that more than some would like, but I am always advocating for what is our healthcare world now and how quickly can we get it into the minds of those who are going to be going out there to work in it. Advocating for an environment that supports us means saying these are the areas that we need support in and doing our best to ensure that we advocate for those. One of the things that I've been working on for the past year has been advocating for an environment where nurses working in mental health who give mental health care, like nurse psychotherapists, have a place in our world, have the ability to do that job. I can't express enough how amazing it was to walk into an office where a nurse sat across from me and listened to the challenges that I had in my workplace, in my home life, and I didn't have to explain to them what I was talking about. Having the ability to connect with another nurse about nursing was mind-blowing for me. And it was my first experience with psychotherapy where I actually felt like walking out of that office felt different than walking into it. So I can't speak highly enough for the ability for nurses to connect with other nurses. And I think that we need to advocate for how important that is, especially in the current healthcare environment. Only another nurse really understands the responsibilities of nursing, the ethical and moral obligation of nursing, and how heavy that weighs on our human self. And that brings me to the part of being human. It's really easy to be, and I think our keynote speaker said it really well, that we do really good at just plowing through stuff and being the best for everyone else. What we do really badly on is being human and accepting that there are times where we're going to need to collapse. There are times when we're going to need to cry. And there are times where we need to step away and say, I'm not a good person for this right now, and I need to take a step back and take a break. All of these things are really important, but ultimately, being human means giving into all of those parts of that holistic lens. When we are being in balance with our feelings, when we are being in balance with our minds, when we're being in balance with all of those things that make us who we are truly being human. And no person, no patient will ever complain about connecting with your humanness. Doesn't make it easy, though. Being human certainly doesn't make being a nurse easy. It sometimes makes it much harder because it means that we have to admit and take care of those areas where we are failing. And we all have them, right? Mine is, I'll be back in 5 minutes, and 15 minutes goes away, and I've barely, scarcely realized that the time has passed. That's my humanness. Taking responsibility for it and saying to my patient, I'm sorry I said 5 minutes. I lost track of time. I'm back now. What can I do to help support you? is taking responsibility and being the professional that I am. But I was also human in that moment, and that is really important, and to give myself grace to be human in that moment. I know we talk a lot about reflective practice. It's built into every province's regulatory nursing body as a essential part of being a nurse. I've moved away from talking about it as reflection a little bit this year with students in particular, because I'm not sure that they truly have understood how important it is. And I've started saying, let's just do a self-check. Have you checked in with yourself? Are you feeling? Are you, all of those things that we need to know, whether it's in professional or personal? I'm walking into my environment that I work in as a nurse. Do a self-check-in. Have I eaten? Have I slept? Have I moved my body? Am I walking in there with a mind that's ready for work? Or do I need to stop and take a minute and take a deep breath and center myself to be able to take on all of those responsibilities and tasks for everybody else's holistic needs, right? So doing that self-check is really vitally important. Building the critical reflective piece into it, I think, is also essential, but it starts with that self-check. Once we've done that self-check and we start to critically analyze and think about all of those things that are part and parcel of what makes us who we are, we can then hopefully discuss, advise, seek support. One of the things is, again, I can't, strongly enough say that connecting with another nurse is so vitally important to our well-being. Being a good friend and colleague is never going to take you in the wrong direction. Being a good friend and colleague means talking to someone who knows what you're talking about, which is really important when you're trying to process through things that are difficult. But it also means celebrating the things that might be small wins in other people's opinion, but for the colleague that you work with, they understand how big some of those small wins are. Making it through a 12-hour shift and not losing your pen. For some people, that's a big win. At least for me, it was when I was working in ICU. Making it through a 12-hour shift and not losing a pen was a huge deal. Making it through a 12-hour shift and not feeling like my whole world was going to burn down because there wasn't enough resources is what some of our colleagues are dealing with right now. Imagine what walking out of that 12-hour shift and feeling the weight of that might feel like if you can share it across two sets of shoulders instead of one. One of the things I'm advocating for in our leadership and hopefully within our nursing leadership is that we really start to think about, have we built reflective time and connective time into our nursing workforce? So if we're working 12-hour shifts, we're expecting nurses to stay after to give reports, to receive reports. But have we also built into that time connection? Should we not maybe be paying nurses to take care of themselves in that time period as well, right? Should we not be making sure that nurses take care of themselves by paying them to take care of themselves in that time period? And why do we do that? Because nurses who take care of themselves and who are able to do that in the environment that they work in provide excellent patient care, and patients have better and more positive outcomes when being taken care of by nurses who are taking care of themselves. So when we build that into our healthcare environments, what we're actually doing is promoting safe and effective patient care. Taking your well-being seriously. Again, I said when I was building this presentation, I used myself as the example. I did not take my well-being seriously for a long time. And I can't say that I had any excuse. I had lots of phenomenal mentors, nurses who told me time in and time out, take care of yourself, take care of yourself. It's important. And it wasn't until I had some serious health scares that I realized that taking care of myself was more than just taking care of myself. It was actually about being well, living well, being a part of my children's lives, being a part of my patients' lives, connecting with them on a human to human level. And that takes me to my next piece, which is be human. In all of our nursingness, and I remember in nursing school being taught by one nurse who said, once you put this nursing cap on, it never comes off. And I held on to that for such a long time until I realized that putting the nursing cap on didn't mean taking the human cap off. It meant adding to my caps that I wear. So we all wear many hats in our lives, right? Like we say in our bio, right? I wear the hat of a mother, the hat of a daughter, the hat of all of these important people to other people. But I also just wear the hat of being human. And so it's important to not lose that when we add new hats to it. And lastly, expect more. This is a big one. I know it looks small on the page, but expecting more, I think, has been my slogan this year. Expecting more, not just from ourselves and our colleagues, but expecting more from the world around us. I think it's important, and I think probably we see this in social media, at least from my literature review and looking at some of the things that nurses are talking about right now. There's a lot of discussion about the patients and patients' families and, their expectations of nurses and our healthcare system. And I wonder, where did they get those expectations? Where did they learn what nurses were and what nurses can do or how they should behave? And where did they learn what our healthcare system was and how it should behave? They learned it from us. So we've established these expectations that nurses can do everything with nothing. We have established the ability to literally create a heavenly experience out of a box of tissues. I can remember going to some of my first shifts as a brand new nurse in ICU and being told by these amazing mentors, don't worry, we'll figure it out. We'll MacGyver it. Right? Nurses are great at MacGyvering stuff. We have entrepreneurial spirits. We are innovators. We are creatives. We are scientists, researchers. We are so many things to so many people. We have taught the public to expect a lot from us. But have we taught the public that we expect more from them? Have we taught the public that we expect them to show up for us and for our healthcare system? Have we advocated what holistic health actually looks like? Have we said, to give you holistic health, we need a healthcare workforce that looks like this, that is representative of our population, that is integrated in all aspects of how we live our lives? It reminded me, I had built this presentation a little while ago, and I went to my son's school to pick him up when he wasn't feeling good. And I said, well, what's wrong, bud? And he said, I have a headache. I was like, well, have you had enough to drink today? Because your water bottle's full. No, I didn't have time to drink today. Like, well, you need to have some water, bud. He's 8. You should know you need to drink some water. Now, nurses are not so good at remembering to drink water either. But it dawned on me as I was walking out of the school, where did school nurses go? Have we advocated to say that we expect more? We expect to have nurses back in places to bring balance to our system. How can we have a holistic view and a holistic workforce if we don't expect to have nurses where they're needed, right? What about all those nurses who are phenomenal at working with young people on the social determinants of health? When did we stop advocating that that was an important part of nursing? Because those are our school nurses. We need to expect more. We need to expect more from our public, expect more from each other as advocates for all areas of nursing. When one nurse stands up and says, this isn't okay, my patients are being hurt, my colleagues are being hurt, all nurses should turn around and say, tell me more. We have to expect more from each other so that we can be human, so that we can take our well-being seriously, and so we can be good friends and good colleagues, which all of those are important in order to have a holistic view, I believe, and in order for us to be holistic beings for our well-being. And lastly, probably my most important part of a holistic view is that you matter. Every single person, every single nurse matters. There is a place in our world for us. And if you haven't heard it enough, I want you to hear it today. You matter. If you don't feel like you matter, reach out. I will tell you you matter. And that's it for me. Thank you.
Thank you, Siobhan. Excellent talk. During the whole time, there's been some actual some lively discussion in the chat, and maybe I'd like to go there first, just to pull out a couple of comments, as well as a couple of questions. Um, the first comment comes from Nicole, um, who's asking, when you had made the comment about finding that nurse colleague to reach out to talk to. She makes the comment about, you need to make sure that that person is open and receptive to that. Maybe could you address, how do you find that right peer or that right individual to to be that support for you professionally and personally?
Yeah, I would say specifically to the person who is like that stiff upper lip person, that seems to be who's gravitating into my chair now, because they're finding that you can only have a stiff upper lip for so long. And then it becomes apathy, and apathy leads to conflict, and conflict leads to an inability to work with colleagues and eventually needing to leave your job, or you have no friends. I would hope before it gets to that point that you can hopefully say to a colleague who's like that something along the lines of, I'm sorry that you feel that the things that are so important to me are not important. But if you ever need to talk about things that are bothering for you, I'm happy to listen. And then you walk away and you find someone like myself or another colleague who understands that every part of your life is important and influences your ability to work. There are lots of us out there, I promise.
Um, there was also some discussion and a question from Lorelei about, we as clinicians, like, how do you manage that tough emotional shift? Like, when we have some of these deep entrenched mindsets of being detached, like, how do you address the emotional impact of a difficult shift, or like, could you speak maybe to that as well?
Yeah. So that's actually something I've been struggling a lot with over the last 6 months or so. And it's why I'm so passionate about this idea that we have to ask for and expect more, demand more. It's also why I have to have realistic expectations for myself. If I only talk about the little hospital that I work with, I see my colleagues struggling and I know what they need. They need debrief, they need reflective time, and they need colleagues like myself who can help them both from a psychotherapeutic perspective, but also from an understanding what they're talking about perspective. Putting those two things together makes a huge difference in ending your shift in a different way than they are right now. But unfortunately, we don't have a healthcare system right now that recognizes that as being exceptionally important. There are programs like EAPs and things like that, and there are some really good therapists within those programs. I've met them, but I just can't quite navigate myself away from the idea that another nurse is the right person for that job. And that we should be and have systems built into place. And I think that's where the advocacy comes in. And maybe that'll be another project I take on at some point, but an advocacy for those types of positions, not accepting that EAP is enough, because it's not, especially not now, not in this system, not in the enormous cracks within our system. We really do need to have another nurse at the table to help run those debriefing sessions and manage those difficult end of shift conversations. And it really is an end of shift conversation. There is another, I wish I had had it with me, but I was reading an article about a small hospital in the Netherlands that's implemented this staggered shift specifically for this purpose. So your shift, if you start at 7 a.m., let's say, ends at 6, the next shift comes on at 6, but then they have debriefing sessions at the end of every shift. So you are actually there from 6 to 7, but you're in a debrief reflective period with your colleagues at the end of that shift. And they said that besides well-being for the nurse going up significantly, patient outcomes and safety flags, they call them, safety flags decreased significantly during doing this, because so many issues that were being identified in these times and were being able to be fixed relatively quickly, because that's one of the things nurses are good at.
That's a really interesting comment. And as an educator as well, we do that for our students. We end their
Right.
shift with a debriefing session, but yet when they transition into professional practice, that ends.
Yeah.
Um, your example is something taken out of nursing education that we do. It sounds like in the chat there was also examples from the NHS and from Australia that might do something similar to that. But it's a very interesting idea, putting in the debrief for the practicing clinician, and the impact of that debrief as far as well-being and then the patient care outcomes. Um, there's all kinds of interesting stuff going into the chat as well. I do have a question for you, something early on, and it was kind of a theme of your discussion when you had said, toughing, like nurses tough it out, and I see things in the chat like stiff upper lip and these mindsets that we have. Um, from a well-being perspective, these are pretty damaging mindsets that have pretty deep roots in nursing as a profession, not just mental health nursing, but nursing in general. And maybe this is a psychotherapist type question, uh, which is again, you're the right person to ask it. How do you challenge, or bring about change of these damaging mindsets when they're so deeply entrenched in what is almost the fabric of being a nurse?
Yeah. I think that's a tough one. And actually, I have like 3 hats on at the moment that want to answer. They're all competing for time. Um, so the educator hat in me says it's why I got into education, is we start with those who aren't in the profession yet, right? So if we want to make long-term change, we have to start with those who aren't in it yet. The second one is sort of my leadership hat that says, change management, going back to the theoretical aspects of how we promote change. Well, organizational change requires a leader who believes in an environment that doesn't tolerate the stiff upper lip. And I think somebody actually put in here, we have to address who we are bringing to those leadership roles and why they're there. I have been in a really privileged position to watch my mom as a new immigrant to Canada, do nursing, and then become a nurse leader, and work her way up from, being an RNA to being the vice president of a Toronto hospital. And in all of that time, the one thing I got to learn and see firsthand in that and living vicariously through that was that she never once gave up that part of nursing that said, how does this impact our ability to care? And sometimes I think that leaders have lost that because they are sometimes forced to, in a lot of ways, refocus on how do we provide more with less. There's a lot of fiscal talk that happens at leadership tables. And it's one of the reasons why I have left a number of leadership positions over the last few years, because when the discussion becomes more fiscally focused without having the conversation also contain how that choice or decision is going to impact those that work within the system and those that have to receive care within the systems, then it's a useless conversation. And then my third hat, the psychotherapy hat, says that when you know better, you do better. And so we have to teach and we have to confront. And so one of the practices I learned in psychotherapy that I've carried into my world, when I'm running into those personalities sometimes, is that confrontation, compassionately confrontation, and say, I recognize that, this is how you've managed for so long. I can't manage that way. It doesn't work for me. It doesn't help me to be healthy or to provide care to my patients in a way that they need. But I have learned other ways. Let me share with you, if you're willing to listen, some of the ways I've learned. And sometimes when you acknowledge that what they're saying isn't wrong from the time that they were taught, right? We're not saying you're bad. We're saying what you learned doesn't work for us anymore. Right? Having the stiff upper lip doesn't work. I don't know if it did 30 or 40 years ago, but I know it doesn't now. But I want to acknowledge your feelings because they're valid. And I want you to acknowledge mine. And I'd like us to share. So I do a lot of confronting, which is probably why you either like me or you hate me. but I don't know how else to change the system. And I don't know how else to support those nurses, because they're also suffering.
Thank you, Siobhan. Very thoughtful response. There was a couple of posts in the chat that I'd like to draw some attention to. One from Charlotte Ross about a article that she's worked on and is completed for peer review, or submitted for peer review. Titled "What Nurse Elders Believe That Novice Nurses Need to Know About Managing Emotional Labor," asking the experts. I'd be very interested. I think there's a lot of us that are very interested in finding out more about that. So, Charlotte, maybe I would just ask, please keep the Federation in mind when you finally get notification of publication. I think many of us would like to find out more about that.
Do.
There,
Thank you.
yeah. There was also a comment from I think it's Matthew, and I hope I'm not saying Matthew. Maybe would you care to speak to the comment,
Yeah.
Matthew?
I can do my best, but it was just that really it was that a lot of the, not even just our own leadership, but I do think actually leadership outside of healthcare systems seems to have this kind of pervasive idea of doing more with less, and that we kind of keep shifting this down onto healthcare workers, and that there's this like overarching understanding that everything has to do with a sort of a fiscal or financial responsibility, that everything is this cost. But we need to either A, radically shift our understanding as a population nationally that caring for individuals will always be a cost, but not one which we can expect profitable returns from. We don't need to be looking at this as if it is some sort of investment. The investment is health, which, I mean, there's enough evidence that's out there that supports that caring for healthcare providers and patients shows a better return on investment because they end up costing
Less.
long-term less. So we need to stop looking at things in these short 4-year turnarounds. We actually, and then I know this is difficult because it's provincially, and I know that each of us where we are located is influenced by whichever political regime is in play. But there is this question of whether or not this needs to be a bit more, well, federally held, because it does need to be national, because across the board, we need to be caring for people no matter where they're at. And I know that we tout universal healthcare, but we also experienced how difficult that is to transition. So it's this conversation, like, how do we care for care providers? We need to start looking that care is necessary, required, and it is a cost that we should shoulder responsibly, like, and that we should take part in that and be happy that we are willing to take part in that and provide that resource for those that are less fortunate, because ultimately a rising tide lifts all boats.
Mhm.
And that is how we need to be caring for people.
Well, we need to have, it's such a great comment, and I wholeheartedly agree. Having sat at some of those provincial and federal tables in those discussions, perspectives like that don't float. And I think, to your point of we need change, I think the changes, and I know I'm harping on the same thing over and over again. Nobody understands that better than a nurse. What would happen if nurses who feel this way and who have the theoretical and experience, not just theoretical understanding of how fiscal management works and how resource management works and leadership and nursing and all of these things that make up the pieces of who could do this well, but also had the philosophical belief of true universal healthcare, which is really what we're talking about. What if they were the people that were in those decision-making capacity seats? What if they were the federal and the provincial healthcare decision makers? What if there was more of them in those positions than less? And right now we are business heavy in the decision-making area when it comes to healthcare, and very healthcare light, because most nurses don't go into business or politics, right? It's not an area that we went to school for. It's not what we wanted to be nurses for. But I'm starting to see that there's a path potentially for us. And it started with the federal government having a chief nursing officer again. It's also about finding the right nurses to be in those positions. And that does need to be a balance of old and new. We have so many generations of nurses working within the healthcare system right now. In order to get everyone on board, it seems that the best way forward is to have representation from all of those areas to be able to learn from the past mistakes and from our current ones, as we know we're certainly making enough of them. That's a great comment. Thank you.
And I saw Michelle had made a reply. Michelle, would you mind putting your question forward, or I can, because Siobhan, your response as far as that pathway forward for leadership within nursing kind of addresses Michelle's comment, which was she was wondering how to bring together the discrepancy or the gap that exists between what we teach student nurses and the experiences of being a worker within the healthcare system. So how do we actually address that change? And I hope I captured it, Michelle, but I give you the opportunity to speak more to your comment if you wish.
Yeah, I'm just thinking, yeah, because there is a gap. I work in professional practice in inpatient mental health, and it is quite, it's different, right? Like how we educate nursing students, what they experience when they're doing their clinical rotations and even in their preceptorship. And then when they actually get to the workplace and now they're a paid worker and they're part of this system. And it can be quite a difficult transition, especially when we don't have a lot of resources put into supporting new graduates, particularly in mental health services. So yeah, just wondering about that. And I guess the gap between like research and evidence and having everything evidence informed when you're in school, and then the reality is that when you work in mental health, you're probably going to be working in inpatient acute mental health care, which it doesn't like match up sometimes. So yeah, just wondering about that.
Gosh, I hope not. I really, really think, well, and then again, I'm the wrong person to ask about this, but for me, mental health is in the community. That's where it starts, and that's where the majority of the work needs to be. If somebody's in an inpatient mental health facility, they're in crisis. So, there's limited stuff that you can do in crisis, because you're just trying to save the person. You're trying to stabilize, and the bulk of the work in mental health is outside of those inpatient units, and we don't have enough nurses doing it. And nurses do this in such a special way. I can't tell you how important it is for nurses to get back out into the community doing this work. And most importantly, my mentor, who was a psychiatric nurse, taught me how important it was for the nurses who are working in inpatient mental health to also be working in community health, because they see that transition period, and their patients, oh my God, their patients do so much better when they have that continued nursing contact from inpatient and outpatient. But I digress. Back to your your point about education is such a good one. It's one of the reasons why when my college, my Polytechnic, when they were looking for people to build the nursing curriculum for the standalone BScN programs, I put my hand up. Did I really have time to do it? No, but I really truly believe in what you're saying, that there's a huge disconnect. There's a gap between what we teach and what we do. And there are ways to build education that minimize that gap. It's one of the reasons why, here's the best question I ever asked sitting at the table. There's 12 or 14 nursing educators sitting around this table talking about building this curriculum. And they're like, okay, so when they go to clinical and there's, 6 or 8 students, and I'm like, hold on. Who said clinical had to be in a group? Why did we decide that was the best way to learn nursing? Why did we decide that one mentor / teacher / whatever you call them, with 6, 7, 8, 10 nursing students running around on a unit or somewhere was the way that nurses learn nursing the best? And they're like, well, I don't know. That's just what we've always done. I was like, okay, but is that the best way for nurses to learn nursing? Because let's be honest, that clinical experience is where the gap gets narrowed, right? It's not in the classroom. We can't narrow the gap between theory and practice in the classroom, but we narrow the gap between theory and practice at the bedside in the clinical area.
For like the first 5 days, like that's a must.
Oh,
So the Tylenol is every day.
So yeah, in clinical is where we narrow that gap. And so my advocation at that table was, well, what does the literature say first? Because we're evidence informed, so let's start there. Well, the literature says that nurses learn best when they are learning one-to-one with another nurse. Okay, so if that's how nurses learn best, why do we not do that? And the feedback I got was, well, because we do it in the very last semester. But why do we do it when they're already done learning? Why do we not do it when they're starting learning? Why do we not do it when they need the protection and the guidance and all of those things? And then I took this to a provincial table where I was told, well, we can't financially afford to do it. Well, why not? Well, because nurses don't want to do it. Why do nurses want to do it? Why does that have anything to do with money? Well, we'd have to pay them. I was like, well, yeah, you would. Because nurses should get paid for educating and for mentorship and for all the things that they do that requires brain and physical activity. Well, we can't afford it. I was like, well, you can't afford not to. Because what we're producing is nurses who have a huge gap in what we should do theoretically and what we are doing in clinical. And what we have right now is also nurses who have experience and have forgotten the theory because they are so run off their feet doing the doing. They don't have time to do the thinking. So we need to pull back. We need to give nurses more of time to do the thinking, time to do the mentorship, and we need to pay them to do it. And we need to put those together with nurses who are learning. So we need to go back to the models where precepted, 1 to 2, max 2 maybe nurses, that seems to be in the literature the most effective model, with a nurse who's getting paid to be that mentor, to be that support person for the entirety of their nursing education. In every piece of literature that I've read, and in every nurse that I've talked to that has experienced that kind of model, not only did they experience less of that gap, but the nurse who did the mentorship actually also reported huge learning, because it gave them that reciprocal knowledge of reinvesting in the theory of why we do things and reinvesting in the evidence-informed piece of why we do things. Because students are great for calling you out when you're doing something just because, right? They're great at saying, well, why are you doing that? That's not what we read about, right? So it brings you back to the, okay, well, you're right. I haven't actually read about what the most recent evidence of this is in the last 5 years. It closes that gap.
I'd like to draw our attention to a post from Dr. Stenhouse. Hi, Rosie. Great to see you. Just to sometimes the solution isn't an internal solution. Sometimes you have to look outside the system for ideas. And Dr. Stenhouse brings the Scottish perspective or the NHS perspective. When you talk about the 2,300 hours, are most of those preceptored hours, or is it still in a group? And could you address your comment a little bit?
Okay, so yes, so we do 2,300 hours of practice across for us 4 years of. Right, sorry, so I got muted again. Is that okay? Yeah. So we so the 2,300 hours is over the 4 years or the 3 years of the programme. It's in clinical placement areas, so it might be wards, it might be with district nurses, health visitors, community mental health nurses, care homes, a whole range of settings. And each student we have a system where we don't call it precepting, we call preceptorship actually when we have the newly graduated nurse and they go into practice, and that's supporting that transition into the role as an autonomous qualified nurse. So the students, when they're out in practice, they have a practice supervisor. So each practice supervisor will generally only have one student. They may not always be on shift with the student, but the student would be expected, the other staff there would be expected to work with that student. And then there's also a practice assessor who is not then responsible really for the teaching of the student, but has conversations with the student, with the practice supervisor. There's also some we have responsibility for getting feedback from patients as well, if that's possible, on their interactions with the student and making the assessment of the student. And each clinical placement is then assessed. Students have to pass their placements if there are difficulties and somebody maybe hasn't developed the levels of competence. We have a whole string of competencies that they have to pass. Then they would have a repeat placement, and there's additional support put in and support plans. But this is mandatory across the UK, so it's a part of all UK nurse education. So all UK nurses are degree educated in universities and all have these 2,300 hours clinical practice. In recent years, some of that's become simulated practice because of challenges of capacity. But yeah.